All right, so today we're going to be talking a little bit about operationalizing advanced care plans. So this is, we've spent a lot of these sessions talking about advanced care planning kind of as an activity unto itself. Today we're talking a little bit more about kind of what happens upstream of that process. So where advanced care plans are stored, how they move around across care settings and stuff like that, and how best to kind of imagine those workflows in your own institution. Again, my name is Matthew Piecha. Our moderator today is going to be John Carney, who's the president and CEO of the Center for Practical Bioethics. Has extensive experience with advanced care planning and end-of-life care. And John, do you want to take this one?
Sure. Thank you, Matthew. It's good to be with you today, and we appreciate everybody joining us for this session of the Ethics Committee Consortium. So we're going to try to get through this quickly in 30 minutes or so we have lots of opportunity for discussion around some of these issues, because I think for many of us, they may be kind of the first time we've really been grappling with them. So just to start us off, the declarations and disclosures that we need to make as participants in this. The Center for Practical Bioethics, as you all know, is an independent community-based organization. We do charge fees occasionally for the services that we provide. Many of you on the call today may not be personally committing those resources, but your organizations have to your benefit. And then we also live basically off of charitable donations. The purpose of this meeting, obviously, is for the educational benefit of all those attending. Our business relationships, I'd like to make sure that everybody understands that I do serve as a community volunteer on the board of LACI. So one of the reasons that the information exchange, as Matthew mentioned earlier, the importance of being able to share these documents across different providers and query them and be able to make sure that we're getting the best information or the most recent information to the clinicians who are caring for the folks, especially those at high risk right now with COVID. So I serve as a volunteer on that board. We also have a relationship with our other partner today, AD Vault, My Directives. Since 2018, we have had a non-remunerative business affiliation agreement with AD Vault as our preferred partner in being able to facilitate the electronic versions of all the work that we do in advanced care planning. Dr. Alex Gamble, who is also a presenter today, is an attending physician at North Kansas City Hospital. And we do have a relationship with them too, as one of the organizations that we have a memorandum of understanding with, as we do with 25 different other hospitals in the region. North Kansas City is also a not-for-profit independent entity. And finally, the conflicts of interest statements that may be important for everybody to understand is that no honoraria or payments were made to any of the participants in today's meeting. No personal benefit can inure to any of us who are representing our nonprofit organizations personally. The benefits to AD Vault, if there are any, would come as a result of the fact that they have a business relationship with LACI, which I'll let them speak to if they would like to. That is a proprietary agreement, and I'm sure is defined within the scope of that contract. And then finally, anybody else who would like to say anything about disclosures or declarations, please do so now. Mike or Jeff?
From LACI's perspective, John, I think you covered it very well.
Okay.
And the same for AD Vault. Thank you.
All right. Okay. Thank you very much. Moving on. So today, as I mentioned, we're going to hear from Dr. Alex Gamble, who's kind of been with the center for what, a couple, 3 years now. He was the palliative care person at Phelps County Hospital in Rolla, Missouri, and was working very closely with us on the effort we have related to medical orders, TPOPP, and advanced care planning. So he's going to share a little bit about his experience and why he thinks that ethics committees can play an important role in advancing this issue. Mike Dittemore, as I mentioned earlier, is the executive director of Lewis & Clark. He'll be sharing kind of the relationship that they have with us and also with obviously a horde of folks in the community in terms of different providers. And then Jeff, who has some solutions related to AD Vault that they've been trying to work on making sure that the information actually gets retrieved and shared and in your hands as clinicians in terms of being able to provide the best care possible to the folks that you're trying to make sure we honor their advanced care planning documents and their medical orders. So in that discussion, we recently had at a LACI meeting a discussion with the CIOs who kind of felt like, well, we think this is great, we think it's important, but we're not sure we're doing a very good job as the CIOs within the hospitals and health systems in making sure that we're sharing these documents. So we kind of posed the question about, well, is there a place or is there a role for ethics committees in helping support the sharing of this information, and also actually making sure that the current documents and the most recent sharings of those people are actually recorded and shared. So we kind of came up with this support for patients and sharing, making sure that shared decision-making works, that we're making sure that we're following the best practices, which is the role the center can play in helping you make sure that goal concordant care is actually provided to your patients through the work that we do. And then also that advanced care planning and advanced directives actually are available so that the medical orders, especially for those of us dealing with people who are quite fragile at this point, actually get executed based on the pertinent information that may be in advanced care planning. And with that, I think I'm going to turn it over to Dr. Alex Gamble, who's going to kind of talk about his experience and let him move through his remarks. We're hoping to be able to tie this up hopefully within the next 20 minutes or so. So take it away, Alex.
Thanks, John. So as John and Matthew had mentioned, I'm Alex Gamble. I'm currently employed at North Kansas City Hospital here in Kansas City, but wanted to share some perspective from the experience that I had in implementing TPOPP, which also brought me in direct contact with a lot of policies around advanced care planning at Phelps Health, which is a 250-bed hospital in Southeast Missouri. One of the last things that I did as I was finishing at Phelps was also helping them kind of reimagine and reinstitute their ethics committee process. And in retrospect, as I think about the lessons that were learned in approaching the advanced care processes there, I think there's a really good case to be made for the way that this work would really have been probably better supported under the auspices of an ethics program. I want to talk a little bit about the lessons that I learned and how that might fit in for ethics committees at any organization and thinking about how to approach these questions. So when I arrived at Phelps, I was tasked with building a palliative care program, but was also handed an invitation to implement TPOPP, which is an advanced care planning document that focuses on patients' preferences for care, particularly folks with serious illnesses at end of life. Wanting to satisfy the stakeholders that had brought me on, I agreed to take that on. And really kind of got to leapfrog a little bit the first point that's here on the slide. So when considering the advanced care planning process and looking at implementing a robust process in any organization, I think the first question is, who really cares about this process? And not just to whom is it important, but also what are the different stakeholders within the organization thinking about what this looks like, the importance, but also the potential risks for bringing in different kinds of documents or approaching those questions. A lot of that work was done before I got there. I'm a very enterprising nurse who is tied into quality improvement, had brought the idea of the TPOPP forward to high-level leadership who were interested in the idea and wanted to see it come forward. What I failed to recognize initially was that there were a number of other stakeholders who had a stake in this question, looking at it from different perspectives, such as risk management, who had different input into that conversation. And so as we got rolling, what I learned the hard way was there were different stakeholders with different notions about this that could create openings for us or potential obstacles that would have to be addressed on the line. So really establishing a good sense of who's tied up in this question, what's important to them with regard to the considerations that come into contact here with advanced care planning for the organization, both in practical terms, but also again for things like risk or how do we improve the patient experience that's there. And thinking about that as broadly as possible, not just in the C-suite, where obviously we'll need to have support if we're going to talk about a process and a policy change, but all the way down to the bedside. Who are the stakeholders that are going to have touch with this? Which really brings us to that next point, which is really thinking through what are the existing and relevant policies. Again, for me, joining an organization and being new to it, that was something that I needed a lot of assistance and support with. So thinking about who are the individuals who own the different policies in our space that can help me understand what's there. Certainly for organizations that have been around for any period of time, often their policy book may be becoming a tome that can be difficult to really search back through. And so looking at, are there policies here that already exist that we're going to need to crosswalk with a new process? Do we want to eliminate or create these? And who, again, are the relevant stakeholders who have control, who gatekeep for those policies? Which, of course, really ties in closely with that next piece. What does the process look like? And this is, I think, where the rubber meets the road. The background of, do we have good support from our administrators? Do we understand where their pain points are? Have we made a good case for what this is about? And I think in the time that we're in right now, there's certainly a lot of active movement in both how providers are reimbursed for having these conversations and what the expectations are for how that's documented and what that's done. We're in, I think, a very dynamic period. So having good support and understanding to that side, knowing what our policies as an organization look like for this, but then again, how does that process look? Understanding that that looks different ways in different places. So who do we have at this table in this discussion? How is that working? And a big part of that is definitely the IT piece. So looking at, when we're talking about advanced care planning, we're not just talking about the discussions, but also their documentation. There's a huge variety of documents that are involved in that. How are they recognized? Who is recognizing them? How do they enter into our system? Do we have a place that works for that? And then having that information flow in both directions. There may be registrars in the ER that are part of this process. Do they understand what it is that they're seeing? Are those documents getting to the right place? Are they accessible by our providers in a timely fashion? If we're talking about the emergency department, we're talking about emergencies. And so are we able to get the information quickly that it can inform care that's being given in a very fast fashion? There are a number of different limitations depending on the system that's in front of us, and having those stakeholders who can speak to that is an important part of that piece. Thinking again about whose responsibility is it? If it's everybody's job, it's nobody's job. So do we have clear definition about the roles? Again, thinking about the admission process in the inpatient, but also our outpatient clinics. Are we motivating these conversations for patients upstream of their potential crisis? And how are all of our clinic staff involved in that? And then that last piece really being, what is our process for clinical and physician education? Again, as we start to think through this process, we can see how many people have contact with these documents, with these conversations. What is our process for educating them and helping them understand, hey, we have new policies and processes that are there. So there's a vast number of stakeholders to be involved in a process and a project like this. Once implemented, there's always going to be an ongoing process of review and revision. Are these new processes working as intended? Are there other opportunities for growth? And I think, again, in retrospect, this really fits neatly into the mandate of an ethics committee, I think, in any organization, both from the standpoint of looking at how our processes work, but how can we continue to improve our organization and really act as a driver for change in an organized fashion with the right kind of support, taking on a process and a project like this to move it forward. And so I think there's obviously opportunities in any organization to improve these processes. The question is, who can shepherd that forward? Having had the experience of being the lone champion to do it, I think it's much better situated in a space and a context where you have an ethics committee to sort of champion that, to bring that conversation initially forward, and also to see that process through, being thoughtful about how all these pieces fit together. So thank you all so much for letting me share my experience. I hope it's helpful. I look forward to taking questions at the end.
Great job, Alex. Thank you very much. And so kind of handing that off then to say, okay, so if you've got the responsibility and you're the champion, how do you know what's available to you and to help make it work? So Mike Dittemore from LACI is going to share a little bit about kind of what role they serve, and all of the hospitals and health systems in the area obviously have an information exchange that they use. So Mike, take it away and kind of help us fill in the missing pieces here for Alex.
Sure, John, happy to. I just want to give a little background about LACI, and also make sure that the audience knows that this is the advanced care documents, the planning, the ability to get those out to the right people at the right time. This is not something that we're trying to put a niche on and make it just for us. We want to make this as inclusive for all other HIOs and all organizations, whether they belong to LACI or not. It's too important to make sure that that information gets to where it needs to be for that patient and those providers to make appropriate care decisions. So LACI, it stands for Lewis and Clark Information Exchange. We are a 501c3 not-for-profit. We're based here in the greater Kansas City area, and we provide services in both Missouri and Kansas. We are one of the 2 approved HIOs in the state of Kansas. Health Information Exchange, basically, you're going to hear a lot of terms that are used back and forth. HIE is basically the verb. It's what we do. HIO is who we are. It's the noun. So through Health Information Exchange, we allow healthcare professionals to appropriately access and securely share patients' information, medical information electronically between their organizations. So those organizations may not have a fiduciary responsibility to one another, but they do have patient care overlap. And primarily what we were focused on is query-based exchange, which is a way that providers can go in, they can search on a patient either through their electronic medical record or through a portal that we have, as do all the other HIOs. And they're able to go out and query information about a specific patient and see if there's any information that resides on that patient at other organizations in the immediate area, but also farther out and sometimes even around the country, depending on the patient's history and the connections that are there. One of the things that we've seen where this is very, very helpful is if you have a patient comes to the emergency room, presents to the emergency room, and they're not communicative, or they are somewhere compromised, that they're not making total sense. They don't have anybody else with them that is a good historian, or they do have someone, but they're not able to really tell a good picture of the patient's health and what they may be on as far as medications and past care and what have you. So this really allows the provider to, instead of becoming a inquisitor and trying to find out all this different information, it lets them become an investigator and go over the information that is available to them, hopefully, on this patient from other organizations. And there's a plethora of different information that's available. Not every organization shares the same information, but one of the areas that we do have in LACI that has been put there specifically for this type of work is an advanced care planning section. So information that is coded appropriately can actually go into that section, so providers don't have to look through other reports or try to dig and find that information that may exist, but no one knows exactly where it's at. So Alex, if you want to go to the next slide. So I apologize for this slide. It's very busy, but that's the beast that's health information exchange. It's very busy, and it can be quite complicated. So what I try to do is just give a very high overview of LACI and how we're connected to different organizations. And then this is not an all-inclusive list underneath where it says LACI participants. That is a good portion of them, but certainly not all-inclusive of our participants. So we are connected directly to the Tiger Institute, which is another HIO. They are at University of Missouri, Columbia. So we have a direct connection to them. So when you query LACI, your query automatically goes out to the Tiger Institute as well, and vice versa. If a person queries Tiger, it automatically comes over and queries LACI and looks for any relevant medical information, clinical information that exists on that patient. We also have connections to eHealth Exchange. That's about as close as you can get to a nationwide health information exchange at this time. And we have connections through eHealth Exchange. So we're connected to the Department of Defense and the Veterans Administration. The only way to connect those two organizations is through eHealth Exchange. Same way with Social Security Administration. They will not do individual connections. You have to go through the eHealth Exchange. DaVita Dialysis is another one. And then the broken lines that you'll see there is Midwest Health Connection, used to be Missouri Health Connection, and Kanza, which used to be KHIN. We are in the process. We will be connecting to those organizations. I believe it'll probably be no later than Q1 of this next year at the latest. So you'll see that information will either is flowing back and forth or will be flowing back and forth from those organizations. And then we have a direct connection to AD Vault. So instead of utilizing eHealth Exchange, which AD Vault is a member of, and utilizing that for the queries, we actually have a direct connection with AD Vault. So it enhances the ability to query and get information back on patients that may have stored information at AD Vault. So we have individuals that have have documented with AD Vault who their register is on record as far as who they want to make medical decisions for them. If they're unable to, they can also store their advanced directive documents, their plan of care. They can put a short video on so that folks can see that, yes, this is the individual and they are absolutely coherent and this is what they want. And so we think it's a very beneficial tool and connection, but we also know that it's been underutilized. And so I really appreciate the panel today and all of your participation, because it was kind of a, if you build it, they will come. And it's built, it's set up, it's ready to go. Some folks have put their information in there and it has been retrieved back, but it is sorely underutilized. And I think it could help a tremendous amount of providers and patients if we had more utilization. Also, this information could then be shared with other connections that we have to help them out as well when they're taking care of patients. So that's basically what I have, John, and I'll turn it back over to you.
All right, thank you, Mike. So let's let Jeff come on. He's the AD Vault person you see at the very top there. We also have a relationship with them through the center, a non-remunerative relationship, as I mentioned earlier. So we are encouraging our people who utilize the electronic version of our documents to also connect with him. So Jeff, take it away, and we'll try to get through the relationship part that you provide, and then we'll open it up for questions and have us all talk a little bit about what we can do to help advance this issue for all those in need. So take it away, Jeff.
Great. Thanks, John, Matthew, everyone at the center, Dr. Gamble. It's great to be with you. Mike Dittemore, we love our partnership with you, and thank you for all you do to try to help the Kansas, Missouri region exchange information better and deliver better care. At the end of the day, that's all we're trying to do at AD Vault on a global scale. We want two people to communicate, and we need them to communicate precisely because one of them can't, and that's in the emergency setting. And it seems like with all the great inventions and discoveries and breakthroughs that humankind has had, we should be able to let two people communicate. And that was the premise when we started this company almost 14 years ago, was to try to figure out a way to get people to document their wishes and then let doctors and nurses find them when they need them and hope to deliver better care. So with that, we'll just go through a pretty clear overview that'll give you some sense. We start with consumers. At the end of the day, we believe people need to be at the center of their own care. You need to have your voice heard in your care. And if we don't do that, the rest of the healthcare system fails. So we say it's a person-centered healthcare system, and this is how we prove it, by starting with people. We do that through the mydirectives.com brand, but that's not enough. So we also help doctors. We help doctors talk about advanced care planning. And Matthew, you can just continue through the slide. We help doctors talk about advanced care planning, giving them tools they might not have gotten in medical school. Maybe advanced care planning is a topic they're not very comfortable with. So we have modules that help doctors talk about advanced care planning, and then not just talk about it, but actually create a document. And then, as you'll see later, we store it so that it can be found when needed, because what good is creating one if it can't be found? We not only help doctors, we help hospitals. And that's that sort of technical integration. We're validated by Cerner, we're validated by Epic, we work with electronic health records all over the world. We have to be agnostic, because if the document is siloed in one particular hospital, how's anyone going to have confidence it can be found in another hospital? That's the magic of what Mike tries to do with exchanging this data. So we're in what we call the cloud above the cloud, and we talk to every one of those electronic healthcare records with modules. We also work with payers, because we believe the health insurance plan is critical to the dialogue with people before they become a patient. And again, people need to create plans in advance. That's why it's called an advanced care plan, so that when Dr. Gamble and his colleagues need it, and when you've actually become a patient, they can find it and use it. In a perfect world, the plan's created in advance, and the payer's a key part of that. So we work with payers as well. And then the glue that pulls this all together is what we call the AD Vault Exchange. That's our global database that talks to all the hospitals, that talks to the health information exchanges, that does all the secure transport of data so that advanced care plans not only can be found, but they go to the right place. And we don't want them buried on tab 45 of some EHR platform somewhere, and then no one gets their voice heard. So the AD Vault Exchange is our global database. We have users in over 50 countries around the world, obviously all of the United States. And we have been working for a lot of years to try to demystify and simplify, get back to the basics. We want two people to communicate. And I'll tell you, the COVID crisis, there is no silver lining. There is absolutely no way to turn this disaster into lemonade, if you will. But it has forced people to look at technology differently and really focus on the core things that are necessary. And as I said earlier, let two people communicate. So I do have two very short videos for you to watch that Matthew's going to play here in a second. The magic of these videos is that someone just took a cell phone and played, hit record and listened to the wishes of two people. They did not get lawyers, they did not get notaries, they did not get witnesses. They did not go through hours of legal forms and massive family discussions. These are two cognitively sane people who were able to have discussions. They were recorded, and we deliver that through Mike's internet, the network of the Health Information Exchange. So doctors could actually watch this video, caregivers could watch this video, each of them are 90 seconds, and decide for yourselves. Dr. Gamble will put the question to you later. Would this help you decide how to treat this particular patient if she were to become a patient? So I'll stop there. There are two, and the reason why there are two is because they both ask for different things. And none of us should have an assumption about what they're going to say until you actually hear them say it. Our wishes for ourselves are important, but our wishes for them are not as important as their wishes for them. And with that, I'll let Matthew roll the two videos. Thank you.
If there is a time that you are suspected to be infected with the coronavirus, or at any point in your medical condition would change rapidly to a point where you might require care beyond what we can provide here, there is an option for you to transfer to the hospital. In consideration of the limited access to the hospital services and the risks associated with transfer at this time, if you have a change in condition, would you prefer to receive the full extent of your care here, or would you prefer to go to the hospital?
I would prefer it here, but I also would like to have access to my own physician to give some direction. I've been with her for years. I trust her, and she knows me.
Absolutely, absolutely. So if something were to happen now, we would keep you here, and our team would do all in our power to keep you comfortable and go with your wishes that you've mapped out and collaborate with your primary care doctor in the community.
Yes.
If there is a time that you are suspected to be infected with the coronavirus, or at any point in your medical condition would change rapidly to the point where you might require care beyond what we can provide here, there is an option to transfer you to the hospital. In consideration of the limited access to hospital services and risks associated with transfers at this time, if you have a change in condition, would you prefer to receive your full extent of care here, or do you prefer to be transferred to the hospital emergency room?
Well, time is of the essence. So I would probably just say, get me to the nearest hospital possible.
Absolutely.
And I would hope and pray that people would grant me my wishes.
Absolutely.
You know, and not look, I heard a story about a place that I don't want to say right now, and they decided that this person was a little bit too old of age, so they decided not to give us the full treatment as they should, because they figured that person has lived their life already. And that was disturbing to me, because age is just a number, and a lot of us still have goals. We still have all kinds of ideas what we want to do, and we should be the ones to know when we are going to go, or the Lord, for God's sakes, but nobody should put that on anybody.
Thank you, Matthew. Again, two very short video clips. They were part of a larger interview that was videoed, but I did notice in the chat window someone asking about families rescinding and overriding wishes, and we can get to this in the Q&A, but I hope people realize that something as powerful as your cell phone, the thing that everyone has, that we happen to call it the most unselfish selfie at the My Directives platform, but just take a selfie video like what you just saw. And I would hope that that would give Dr. Gamble a little more confidence when he's developing a treatment plan for those two women, to understand what it is their goals are, who they would like included in the conversation, and for families that are confused or that would have pressure to maybe rescind wishes when you see your loved one very calmly walking through their wishes without a gun to their head, without reading from a script, without being under stress or medication. I think we can all agree that we're using technology to deliver better care. And so with that, I'll stop and appreciate the chance to visit with you all today.
All right.
All right, thank you. Oh, go ahead, Matthew. Go ahead.
Yep. And before we move into kind of the panel discussion, we just wanted to kind of provide this this scaffold kind of for both our discussion here and for a potential project for ethics committees that are interested in maybe exploring this in 2021. So kind of the core question that we're really interested in is the one that is asked by a provider to a patient in the care setting, that is, do you have an advance directive? So this is a question that is kind of there's a mandate behind it, but there is not always a lot of robust follow-up. And so kind of exploring the two possible ways that that question can go, like if yes, what happens, and the types of workflows and resources that should trigger, and if no, what happens and what types of workflows and resources that should trigger. So for ethics committees that are members of the consortium, we'd like to encourage you to consider taking on kind of an investigation of this question in your own institution, and connect with us and with the other committees in the consortium to try and sort of make more robust the institutional response to the various answers that you can get from this question.
All right, thank you, Matthew. Let's go ahead and as Matthew kind of cues up the Q&A, I did want to go back to kind of Jeff's question to Alex, maybe to kick us off. So Alex, if those videos were available to you, would it make a difference as a palliative care doc in an acute care setting if you had nothing other than basically somebody saying mom's sick and she needs help?
So absolutely. I mean, I loved watching the clips. I think they're really true to my experience and having those conversations with patients and seeing that conversation happening upstream and being able to hear the patient's voice. You know, we often say from fellowship training, Dr. Carney Porter Williamson always really impressed on us the idea that it's the goals of care that dictate the plan of care. The way I often formulate that for patients is how we treat you is not a medical question. It's a question of your personal values and your goals. And so to have a ready clip of a patient expressing their direct wishes to the specific scenario that they may face would be invaluable, totally invaluable. I would also address, I noticed this question in the Q&A about families overriding these documents. And I think definitely the answer to that question is going to vary based on setting, but it raises another question that I think really brings home how neatly this question fits into an ethics committee's work. What we're talking about are processes and specific structures that are complex and difficult, and we're hearing about really robust answers that exist to help us with that. But what belies that is, what is our culture of practice? If we think about the ethics committee as the conscience of the organization, the question is, how does our organization think about the importance of having these conversations? How and when and where are we engaging our patients in the most important question? What are your goals for your care? And so we're talking about really putting the processes in place to know that there's an expectation for that conversation to happen, to engage all of our stakeholders in that conversation, and to make it actionable. But the biggest thing is bringing that question. So to get back to this question, what is occurring when families are trying to override a patient's clearly documented wishes? The goal in general is not to override the patient's wishes, it's that they're faced with an emotionally devastating circumstance that they have not had the time to consider and process. The benefit that we have in this documentation, whether it would be for them to be able to see that clip with their own eyes and hear it with their own ears, or to review the document, which is frequently what we're doing in our role in palliative care, is to bring the patient's voice back into the discussion. We have a devastated family member in a moment of crisis who's thinking about losing someone that they cannot lose. And that's leading them to this place of trying to override a wish. If we have documentation, we can reintroduce the patient's voice to that conversation. When you're thinking about this in the crisis setting, it's typically someone who had not had an opportunity to talk to the patient. They can't speak from experience and say, I know what your mom wants because she told me. But if it's documented, we can bring it forward in that way. Again, this underscores the importance of education, that the providers feel confident to have that discussion. And certainly that's something that we've seen in a lot of different settings. In implementing TPOPP, we were hearing from EMS in the field having that experience of being able to come to a code where the family is saying, I don't care, I want you to do everything. And EMS being able to gently say, I hear what you're saying. What this document tells me is that your loved one said they didn't want to go through that. And what we want in this moment is to honor their wish and support them in being able to bring that grieving, devastated family member back into the discussion we're trying to have, which is centering the patient's understood wishes. Certainly this doesn't obviate that process, but it's a really important tool to that piece and supporting this culture of, are we putting the patient's goals at the center of care? And so to answer the question briefly, yes, that clip would be so helpful in practice. And I think the more robust we get with this, the better off we are.
Thank you. We got a number of questions I think we need to get to, so I'm going to kind of turn it over to Matthew and let him kind of shepherd them through.
Sure.
I will take Connie's, Matthew, but go ahead and start with Art, I guess, or whichever one you want to. Go ahead.
Okay. Yeah, I've got a question here from Art for Mike. It says, how extensive is the LACI network of EMR access? Is the portal compatible with other platforms outside of your regional network? And is patient access de-identified, or would HIPAA permissions obviate this?
Great questions. It's a fairly extensive platform. We're vendor agnostic. We do operate off of a Cerner platform, but we have connections to Epic, Allscripts, Meditech, NextGen, eClinicalWorks, just a variety. I think right now there's around 15 or 16 different EMRs that we're connected to. How folks view the information is up to them. There's a couple choices. They can choose to view information through the viewer that's available in their electronic medical record, or the vast majority. We have seen in a few instances with some smaller clinics or federally qualified health centers that they have actually preferred to use the portal. So instead of using the view that's embedded into their EMR, there was some limitations on what that viewer could show. They prefer to use the portal because the portal will enable anything that's being shared through LACI to be viewed. So that's kind of where we're at with the portal and the different EMRs. The information coming across through LACI is used for treatment purposes. We do have a couple initiatives where we've worked with a company with the organization's permission, of course, that they can provide information for life insurance companies if a patient is wanting to take out a life insurance policy. And of course, that's a fully vetted, fully opted in query that's done. Other than that, everything is for treatment purposes. So the information is not de-identified, it's fully identified. But we do not use LACI information for research. We don't sell LACI, well, it's not LACI's information. We don't sell our participants' information. We don't sell any type of research rights or anything of that nature. It's truly for treatment is the 99% of it. And then we do have a couple initiatives where we work with life insurance underwriters.
All right, thanks, Mike. And I've got a question here from Connie. I'm going to direct this one to Jeff. It says, how easily can the directives be changed once they are archived? We always educate that decisions can be changed at any time.
Connie, that's a great question. And it really gets to one of the fundamental obstacles to the growth of advanced care planning that John and great folks that wrote in a report to Congress back in 2008, 2009, these problems have been around for a long time, and that psychological barrier that if I sign this form, it can never be changed, causes people to hesitate to create the form in the first place. Not to mention, if you feel that you have to spend money on an attorney or a doctor's appointment and you have to come out of pocket for that, and then there's a document, you might procrastinate, especially if you didn't have confidence the document was ever going to be found. So the whole solution suite, if you will, for advanced care planning, it gets back to that person-centered need to say, if I want to have a voice in my care, do I do it now in advance when I have no idea when I'm going to have a car accident, when I have no idea what ambulance is going to pick me up and take me to what hospital, what electronic health record they might be on? Quite frankly, to LACI, which health information exchange they might even be connected to. So how would they ever find it? So why would I even bother doing it in advance? But once you give the consumers confidence, once you tell your patients and your staff at your facilities confidence that their voice can be found, they feel more confident creating it. Now, the next piece is, can they create it in such a way that they can update it? At our system at mydirectives.com, which is completely free to consumers, yes, you toggle a switch, you can change your mind. It's no different than going from an aisle seat to a window seat on your flight. You should be able to change your answers. We want you to think through them. If you were to change your answers that then conflicted with another answer, our particular system is smart enough to have a box pop up and it says, Connie, you just answered this, which seems to be in conflict with this. Would you like to go back and change that? So we're trying to drive better quality documents, not just a whole host of documents. We want Dr. Gamble to have something meaningful to look at. But if you do have a paper document, and by the way, the Caring Conversations document from the Center for Practical Bioethics is one of the best workbooks and one of the best tools that's out there. What John, Myra, and Linda Ward, and Matthew, and the folks at the center have done is breakthrough. And you are so lucky to have them in your community and to bring them into your facilities and help train people to do better conversations and great, meaningful documents. Of course, those can be updated. You just have to create a new paper document. In our system, you can delete the document you uploaded if you had uploaded the paper document, and anyone can go to practicalbioethics.org, click on the My Directives logo, and for free upload your paper document. If you happen to use a 5 Wishes document, for example, you could go to 5wishes.org, click on the My Directives logo, and upload it for free into our database. We're going to give Dr. Gamble and every physician out there access to any information you give us, as long as you give it to us in a safe, secure way. And then we work with Mike Dittemore and all the other health information exchange people to make sure we're delivering it into the electronic health record in the safe place. You want to update your answers? Please do. And if there are competing documents, for example, if someone forgot to delete one and they had 2, well, they're time and date stamped. And yes, the can will have been somewhat kicked down the road in the sense that someone in the ER is going to say, Jeff has 3 documents, which one do we honor? We would hope you would look at the documents, figure out which is the most recent. That should be the one you honor. If you feel the most recent isn't as qualified a document as a prior one, well, that's where medical ethics committees come into play. That's where common sense comes into play. That's where knowing who the healthcare agent and being able to contact them comes into play and say, maybe there's a patient mismatch and we have documents from 2 different people. That would be a terrible mistake to make, but it happens. Maybe we have 2 different documents and someone forgot they didn't delete the one from 10 years ago. That would be a terrible mistake to make, but it happens. Dr. Gamble lives in a world where mistakes can happen every day, 24 hours a day, and we're trying to provide a tool so that he can make less mistakes and make better decisions.
I want to piggyback on that because I think this is really important in terms of the role that the center can play too in helping train people about this. So Connie, first of all, if the person has capacity and can make decisions for themselves, there is no need to rely on a document. So I think we need to make sure, and Alex would be the first person to ask that. If you've got a patient in front of you and you've got an advanced care planning document, you're checking with them to make sure that it's accurate and it's still in play. So I think that's the most important thing. But that's part of the training that we do. That's part of the education that the hospitals can rely on the center for. It's part of your agreement that you have with us if you've already got a basic agreement with the center. And it's, as Jeff said, and I think Alex has alluded to, they take information. That this information is not necessarily, hard, fast rule you've got to follow an absolutely necessity. You're going to make, clinicians are never relieved of the responsibility to make medical judgments in the moment. And so that standard has to apply. So we reinforce that with our education to say, this is the best information you have available. And if it's a medical order, that may be treated differently within your institution as an expression from a patient. So those are all aspects that need to be at the hands of the individual. But you are absolutely right. We should be using these as resources and tools and not necessarily as documents that somebody can beat somebody up with. It's more around what's the best information we have in order for us to be able to go forward. So I want to give Alex an opportunity to weigh in here too, because I do think that this is really important. There are times when you appear to have conflicting information, or you may have an expression of the patient that says, I don't want that anymore. I want you guys to do everything you can. We found that particularly true in this situation with COVID, is that people are wanting specific COVID related documents to be initiated. We've got resources to do that, but they want to say, I only want this if I can't go to the hospital, or if going to the hospital means I'm going to end up in the ICU or on a vent kind of thing. So those judgments need to be, they're all, you know, time sensitive, and we need to make sure that we're doing it. So Alex, I don't know if I'm stealing your thunder here, but go ahead.
No, not at all. I think I would certainly support the perspective that you're sharing. I mean, absolutely, there's nothing that alleviates the need to have a clinical process and to think about the patient that's in front of me and the information that's there. What I think this really provides is more information that traditionally has not been available to us, as well as, and if it's okay, I'd dovetail into the question I'm seeing here about how to move these conversations upstream with the PCP. But again, are we having these conversations at all? Is this data available to us? You know, one of the most difficult situations that we face in the inpatient palliative care space is talking with family members, number one, orienting to the idea that we're asking them to help us hear their loved one's voice, not asking them what they want, which is an undue burden, and facing families who have never had these conversations at all. Again, because they're hard conversations to have, but also a lot of folks aren't aware that they need to be happening. That's the responsibility of the health system. So moving these conversations upstream so that people have the time. In my earlier remarks about these overriding moments, again, understanding that there's an intense emotional component of this. If the first time you're faced with the gravity of these decisions is in the moment itself, it's very difficult to move through the emotions of that to get to a good answer, one that understands and supports your loved one's wishes. It's much harder if you've never talked about that before. It's much harder if you haven't had the time to start to think about, internalize, and process that. So moving upstream has a number of important benefits and really makes our work easier in terms of that most important goal of hearing the patient's voice, understanding their goals. And so absolutely, that ties into the question about the policy piece. Is my policy clearly outlining how these documents fit in, how they're integrated, what the expectation is for integration into clinical decision-making, while also, you know, supporting and giving primacy to that clinical decision-making space, right? That the providers are not tied to the words of a document because they may seem to be in conflict, because the patient's wishes do change. When we talk about the goals of the patient driving the plan of care, an important understanding is that goals change, and in both directions. In general, there's a movement toward more comfort-focused care in time, but especially right around that inflection point, how patients think about how their goals are shifting. Things may change based on how they're feeling day to day, and we need to be flexible. COVID, I think, also is really pointing out that the information that we have makes a big difference. This is a novel coronavirus. It's something that we're learning about every day. And as we get more information, people are going to integrate that differently and think about it differently. So we need to have processes that are bringing good information forward in a timely fashion to allow patients to consider how it affects their goals and wishes, documenting it effectively and having access to it. And that's really putting all of those pieces together. What are our policies to support that? What are our processes to support that, including education and staff? If it's, I know I'm kind of running. Matthew, is it okay if I address Kim Fuller's question here? So to that question about the PCP, that was really the step that we were on when I exited from Phelps, was really trying to look at how that works. Like any technology or any innovation, as you introduce the idea to people, you're going to have kind of a bell curve of adoption. You're going to have people out on the far end who get it right away and want to be on board and move forward. What we saw at Phelps was when we put these items into action, there were providers who were clamoring for this and who scheduled all of their patients to have these discussions and document it as this TPOPP document had become available. There were other providers a little further back on the curve who saw the benefit, but didn't really see how it fit into their workflow or weren't really sure how to make that work in their setting, whether that's in the hospital or in the clinic. And then folks who maybe were dragging their feet a little bit more. And so when you think about implementation, you want to identify those champions and proponents, the people that are on board, to help them spread the word and the excitement, but also as forerunners. And so what we were working on as I was leaving Phelps was working with our early adopters, the ones that were really on board, to look at what were their processes, how had they integrated this, and then start to make a roadmap for other providers. I think when we look again into 2021 and what the center's offering here is exactly that kind of process, to look at the different settings that we're in, what are the roadmaps, what are some workflows that we can integrate to really lower the barrier to entry. Again, our providers are really busy right now. Everyone's in a crisis. COVID is sucking up all the oxygen in every care setting. And so the more that we can do to be supported and to show this is a way that this can work. This is who on your staff, for the setting that you're in, who on your staff can take on these pieces. The other part, I think, and really as we think about how do we shift culture, a big part of that is relationship. So in a given setting, what are your relationships like with those providers? Are there administrative incentives that can be put into place to encourage them to explore and to think about and see the importance of this? Are there other ways that we can make this work for them? Do they understand that they can bill for these conversations and what the expectations are around that? So I think really looking at multimodal strategies for integrating this into a process, as well as advancing a culture. How do we think about these conversations and their importance? And then these practical matters that I think LACI and AD Vault really offer a unique opportunity to address a lot of these really difficult to answer questions to make an impact where it counts at the point.
Yeah, I'd like to jump in here just quickly. I know there's a question on TPOPP, and so part of what Alex is talking about is differentiating between what are advanced care planning documents and then what medical orders. The advanced care planning documents inform the medical orders, so they come later, and they're also very specific to particular kinds of people with very serious illnesses. So the advanced care planning documents, the naming of the agent and setting your healthcare directive or doing your living will are obviously very important, that feed into then when you have a serious illness or you've got a particular condition and you've got limited life sustaining treatment, maybe efforts that you want extended on you, or you're saying, okay, if I'm found, if I've died, if you're found pulseless and I'm not breathing, then leave me alone. But if short of that, if you find me, here's the aggressiveness of that I want to be able to make sure happens for me. So those kind of documents happen in that medical order set. Those are two different things. We can set up training programs for you to differentiate the two. They're not in the same category, though they often end up in advanced care planning spots on the medical record, but it's very important that we understand the difference between that. I know, Matthew, you've got a bunch of other questions here we need to get to, but I just wanted to bring that up.
Oh, I would add, I saw Maria's comment pop up, and thank you, Maria, absolutely. And I have not articulated this that clearly. My comments have mostly focused on the provider part because often that's where the billing revolves around. But when I talk about integrating a process, that's exactly what I'm talking about, because you're absolutely right. Upstreaming, a big benefit of upstreaming these discussions is because we're able to take advantage of those deep relationships across everyone who's touching our patients. And so definitely thinking about the process pathways in the outpatient clinic is, how do we get the nurses involved? How do we empower them to have these conversations? Often our staff are in a position where they're being faced with these questions by the patient because there's a sense of nervousness to open some of these discussions with their physician or their other provider. But they're asking those questions and talking to the nurse and the social worker, the other folks that are in the clinic that they trust, that they do have that deep relationship with. And so when we think about an optimized process, it's one that allows everybody to participate in, that everyone has a role to bring this information forward, to engage with our patients and make them feel heard. There's a lot that's there. And so really, again, not thinking about this as this is a conversation you had just with your doctor, but how does your care team with everyone that's involved in that process fit into that piece? How do they understand it? How do they engage it? How do they participate in the process in whatever setting you're in? So thank you for raising that point and keeping me accountable, Maria. I appreciate that.
All right, I think we might have time for one more.
Matthew, I can take Connie's question about have you seen an increase in advanced directives? I just wanted, there is one study that has been released that during the time of COVID, there has been in one particular study, evidence that there has been about between a 30 and a 50% increase in the number of inquiries that have been posed by clinicians about it. We aren't sure that people are necessarily executing them, but we do know that they've been requested and there's more that are being queried on it than necessarily, but there has been certainly with the COVID much more attention put on this issue.
I can add to that from our perspective as a technology company. Obviously, you see data. We see a significant increase in people starting advanced care plans. We see a much greater significant increase in people returning to their prior plans and updating them, reaffirming them. And then on our platform, they're pushing a button and they're sharing them with family members and friends and just saying, just a reminder, this is where it is. This is where I have it. Oh, by the way, can I get this to my doctor? We're seeing a significant increase in the creation, the storage, the updating, and as well, people uploading their paper-based plans. They finally went to the shoebox or the safe deposit box. They found the one they did on paper and they said, well, okay, might not be perfect, but it's better than nothing, and I better have something during this time period. So let me upload that. So we're seeing an increase in all of that.
Well, and a lot of that has to do with the fact that people are not oftentimes allowed to accompany someone in there, and the patient may not have the document, but somebody else does. But if you can't even get inside the door because of that, then electronic means is the better way for that to happen. So.
Well, and that's exactly my point, John. With infection risk on a piece of paper, we see lots of hospitals, chaplaincies, we see lots of people saying, no, we won't take the paper, which means it has to get there digitally. And the best way to do that digitally is to get it into a database so that the Mike Dittemores of the world can get it into your hospital electronic health record, or you can share it digitally from your phone, from our platform, which is the way we designed mydirectives.com. Again, great question, significant increase. We need to do more. And if you did nothing else today, if you just got yourself your own plan, and I would imagine some of you probably don't have them and don't want to admit it, if you just yourself named a healthcare agent, and I bet you think you do, but you don't, if you just did nothing more than name a healthcare agent and encourage a loved one to do the same, you'd make a very big difference. Every journey starts with one little step, and the little step is who speaks for me in the event of a crisis. Again, at mydirectives.com, you just click the button to name a healthcare agent. It takes less than 2 minutes. Do it, name it, they'll get it. They get to confirm that they are, and you're done. You want to answer the other questions and have a full plan? Great. Reach out to the center, have a full-blown discussion and go through the workbook and create a plan. That's even better. The more you give Dr. Gamble, the more information he's going to have. And that's our goal, is to give him better tools to understand you better.
And in the interest of completionism, we have one last here, and it's what does the staff person mean in consideration of limited access to hospital services, which I assume was referring to the video clips. I assume that just refers to considerations based on COVID and scarce resources and stuff like that, right?
Yes, Suzanne, it's a great question. Those two were residents in a long-term post-acute care facility. So they had limited access to what they could do on site.
I see. All right, and I think to wrap up, we've got one more slide. I'd like to thank our panelists and moderator today for contributing their time and effort to this program. And just remind everyone that this is the Ethics Committee Consortium series. And as we're kind of wrapping up the year, we're starting to kind of pull together our programming for next year. And if this program has inspired some interest in trying to in taking on a project in your own ethics committee to sort of investigate ways that operationalizing advanced care plans could be improved in your institutions, we'd like to hear from you. You can email me. I'll go ahead and drop my email address into chat if you don't already have it. And we would like to actually design some of our programming around kind of tackling this problem at the consortium level. So if you are interested and your committee is interested in sort of collaborating with us on this, let us know, and we'll see if we can pull together resources for you and maybe some future workshops in 2021. So with that, John, do we have any other last minute?
Great job. Great job. Thank you very much. And just follow up with Matthew, and we'll be happy to work with all of you in the coming year. So Alex, Mike, Jeff, thank you very much. It's been a great presentation. So
thanks very much. You can find the recording on YouTube. Thanks.